ഇവിടെ സ്റ്റാർട്ട് ചെയ്തു.
Good evening, doctors. So today we'll be discussing about the NEET MDS question papers and of the previous years, that is in 2024 and 2023. We'll be mainly covering the general medicine questions, what all questions have come in the previous years. So let's begin going to the first question. Yeah. So the first question is, a 55-year-old male smoker presents with a history of persistent neck pain and a sinus opening in the cervical region. On examination, matted lymph nodes are palpable. What underlying condition should be considered? So here we need to note that there is a persistent neck pain for the patient and a sinus opening in the cervical region. There is also matted lymph nodes. So the options given are A. Tuberculosis, basal cell carcinoma, lymphoma, and osteoma. So mainly in the cervical region, when there is a matted lymph nodes, we need to suspect it as tuberculosis. So it is tuberculosis lymphadenitis or scrofula. Tuberculosis lymphadenitis is also called as scrofula. So as we all know, the causative organism for tuberculosis is Mycobacterium tuberculosis. And the site is mainly the neck lymph nodes. And in the neck, we can mainly see it in the upper deep cervical lymph nodes. And the next common site is a posterior triangle lymph nodes. And it can also be seen in other lymph nodes in the axillary, para-aortic, mesenteric, and inguinal lymph nodes. And it is also this tuberculosis is also associated mainly in HIV patients. We need to suspect tuberculosis in AIDS patients as well as lymphoma patients also. And the most common, the most prominent feature of tuberculosis is matted firm lymph nodes, which can be seen in pathology. When you take the cut section, you can see this firm matted lymph nodes with a yellowish cassating material. So what is the stage 1 and stage 2 of tuberculosis? Stage 1, where there is swelling of the lymph nodes, that is lymphadenitis, and stage 2 is matted lymph nodes. Matted lymph nodes means there will be a group of lymph nodes which will be palpable. Yeah. So that is the first question. And going to the second question, which of the following criteria are a part of curve 65, that is CURB 65, for assessing pneumonia severity, excluding one? So the options are age, blood pressure, BUN, that is blood, urea, nitrogen, and fever. So the excluding one, they're asking for the exclusion, which is not there in curve 65, and that is fever. So curve 65 is mainly for assessing community acquired pneumonia. So it is a mental test score of 8 or less, or it is mainly we are checking the orientation of the patient. So what does curve 65 mean? That is CURB is standing for confusion, C for confusion, U for urea, which should be more than 7 molecular per liter, or it is respiratory rate, which is more than 30 per minute, or it is blood pressure, when the blood pressure is going less than, that is systolic pressure is less than 90 mmHg, and diastolic pressure is less than 60 mmHg. So that's an error. It should be 60 mmHg. And if the age of the patient is more than 65 years. So once again, it is CURB, C standing for confusion, U for urea, which is more than 20 mg per liter, and respiratory rate, which is more than 30 minutes, 30 per second, and blood pressure, if it is going below 90 by 60 mmHg, and age of more than 65 years. So curve 65, there is a scoring criteria for this one also, which is 0 to 1, 2, and 3, or more than 3. So 0 to 1 means the patient can stay at home and home treatment is enough for the patient. And if the patient is having a score of 2, it should be considered as a hospital supervised treatment, which is a short stay inpatient. The patient should be admitted for a short stay, or it should be a hospital supervised outpatient. And for three or more, it should be managed in hospital because it is the case of severe pneumonia, and it should be assessed in the ICU, especially if it is more than three, that is four or five. If the score is becoming four or five, then it should be for ICU admission. So it is CURB 65 CURB, remember. So the third question is normal anion gap. Normal anion gap is present in option one, diarrhea, diabetic ketoacidosis, starvation acidosis, and lactic acidosis. So one among this is normal anion gap, and the others are high acidic anion gap. So the first answer, that is diarrhea, is the example of a normal anion gap. So all the other conditions, that is diabetic ketoacidosis, starvation acidosis, and lactic acidosis, all of the three are examples of high anion gap. So what is the difference between this normal anion gap and high anion gap? Normal anion gap means when there is an increase in the acidic content of the body. That is, when it is not removed by the kidneys, there can be high acidosis. But in normal anion gap, there is no change in the pH of the body. But in a high anion gap, there is a change in the pH. That is, the pH will be reduced. So what are the examples of high anion gap? It is diabetic ketoacidosis, can be starvation ketoacidosis, and lactic acidosis. So that is, again, when acid anions such as acetoacetate and lactate accumulate in the extracellular fluid, the anion gap is increasing, which is leading to high anion gap acidosis. So the examples again are lactic acidosis, ketoacidosis, alcoholic patients, as well as starvation. Fourth question is, which of the following describes a characteristic of type 2 respiratory failure? So in this case, we need to know what are the four types of respiratory failure. It is 1, 2, 3, and 4. So the options given here are hypercapnia without hypoxemia, hypocapnia without hypoxemia, hypercapnia with hypoxemia, and hypocapnia with hypoxemia. So type 2 respiratory failure, what is a characteristic feature of type 2 respiratory failure? It is hypercapnia. So it is hypercapnia with hypoxemia. That is, the third option is the right answer. So type 1 respiratory failure is hypoxemic respiratory failure. Hypoxemic means when the partial pressure of oxygen is less than 60 mmHg with a normal or low arterial carbon dioxide tension. So this can be because of pneumonia, AIDS, pulmonary embolism, and pulmonary edema. Type 2 means it is hypercapnic. What is hypercapnia? When the partial pressure of carbon dioxide is high, that is more than 50 mmHg. It can also be associated with hypoxemia. So this can be hypercapnia, or type 2 respiratory failure can be because of drug overdosage, COPD, chest wall abnormalities, and asthma. And type 3 failure is post-operative atelectasis, and type 4 failure is decreased blood flow to the respiratory muscles. So type 1, 2, and 1, 2, 3, and 4. 1 is hypoxemia, 2 is hypercapnia, which can be accompanied with hypoxemia also. Fifth question is, which statement regarding LDH is lactate dehydrogenase, is correct? The first option is LDH1 by LDH2 ratio is increased in myocardial infarction. LDH is a potent marker than troponin. LDH level is secreted in blood. LDH peaks around 10 to 24 hours. So lactate dehydrogenase is an enzyme which is produced by our body. So this increases when there is a damage or injury in our body. So it is actually an important marker of heart, liver diseases, fracture, bone fracture, etc. So in this case, the correct option is LDH1 by LDH2 ratio is increased in myocardial infarction. Because troponin again is an important marker than LDH. Yeah. So LDH was previously, it was used as a marker for myocardial infarction, but it is not of use now in the clinical practice. Nowadays, we do use troponin as an important marker for myocardial infarction. So LDH is the last enzyme which rises in myocardial infarction, and the last one which returns to normal level also. And it also has a limited diagnostic value. But in normal conditions, we can see that the LDH1 will be lesser than LDH2. So LDH is having its isotopes, that is, it is having LDH1, 2, 3, and it has got 5 isotopes. So in normal conditions, it will be LDH1, which is lesser than LDH2. But in myocardial infarction, it is reversed, which is also called as flipping pattern. Flipping pattern means when there is a rise in LDH1 by LDH2. So that is seen in myocardial infarction. Okay. So the next question, a patient is displaying symptoms of imbalance, ataxia, dysdiadochokinesia, likely has a lesion in which part of the serum. So we need to understand here the patient is having symptoms. What are the symptoms? Imbalance, ataxia, and diadochokinesia. So which part of this which part of the brain will cause these symptoms? Like when there's a lesion in which part of the brain, there will be imbalance, ataxia, and dysdiadochokinesia. We need to know that. So the options here are cerebrum, cerebellum, hypothalamus, and basal ganglia. So the right answer here is option 2, which is cerebellum, because cerebellar ataxia. Ataxia means that is like uncoordinated movements. That is cerebellar ataxia. So that broad-based gait and lateral cerebellar lobe disease, and stands broad-based and incoordinated. So that the patient's movement will be incoordinated. That is ataxia. And dysdiadochokinesia is the inability of the patient to perform alternating movements smoothly and rapidly. So alternating movements is not happening for the patient smoothly and rapidly. That is there, and ataxia is also there. So these symptoms are seen when there is a lesion in the cerebellum. And how do we diagnose this lesion? It can be by an MRI or a CT scan. Yeah. Next question. What is the minimum time frame for administering post-exposure prophylaxis following exposure to HIV? So post-exposure prophylaxis, we are coming in contact, especially the dentists, when we come in contact with the HIV patients. What is the first precaution we take? That is called as post-exposure prophylaxis. So this post-exposure prophylaxis has to be given to the patient within a limited time frame. So what is that? The options given are 2 hours, 48 hours, 72 hours, and 4 hours. So here the correct option is 72 hours. So all puncture wounds, because when we are treating a patient and we get a needle prick, prick, and the mucous membrane, needle prick, and the mucous membrane is yeah, yeah, when there is a puncture in the mucous membrane, you have to take care that, and the healthcare workers have to involve the blood from the patient with the HIV infection. They have to be treated prophylactically with combination of antiretroviral therapy. So this prophylaxis, which is given after exposure to an HIV infected patient, is called as post-exposure prophylaxis. So this post-exposure prophylaxis has to be given within 72 hours of exposure. And the first dose should be given within 6 to 8 hours of exposure. The first dose should be given within 6 to 8 hours of exposure, and the follow-up is within 72 hours of exposure after you get the prick. So even after the 72 hours of exposure, if you are treating this prophylactic treatment, there is no point. Yeah. So this post exposure prophylaxis, if the exposed person is also HIV infected, they should not be given to the patient. So what is the regimen for, what is the antiretroviral therapy for post exposure prophylaxis? So the regimen, there is like basic regimen and expanded regimen. So the basic regimen includes of zidovudin and lamivudin. Zidovudin we give 200 mg thrice daily, that is TID, and lamivudin is 150 mg BID, 2 times daily for 4 weeks. And the expanded regimen is consisting of indinavir and nelfinavir, which is 800 mg and 750 mg TID, respectively. So indinavir and nelfinavir are protease inhibitors, and zidovudin and lamivudin are nucleic acid reverse transcriptase inhibitors. So that is a regimen consists of a basic regimen and an expanded regimen. So once you are exposed to an HIV infected person, it is called as post-exposure prophylaxis. And the first appointment is the first dose is within 6 to 8 hours, and the follow-up appointments is within 72 hours of exposure. Next question is diazepam is a drug of choice for which of the following condition? Anaphylaxis, myocardial infarction, seizures, and angina. So in this case, we need to know which class of drug is diazepam belonging to. So diazepam is an anxiolytic drug. It is a drug of choice for anxiety. So it is a drug of choice for seizures. So the options were anaphylaxis, myocardial infarction, seizures, and angina. So the correct option is option number 3, which is seizures. Yeah. So for seizures, there is first aid management as well as office management. So what are the first aid management for seizures? First one is we have to move the patient away from danger. And the second one, we need to make sure that the airway of the patient is clear. And if the convulsion is continuing for more than 5 minutes or it is recurring without the patient getting regaining the consciousness, then we need to go for a medical attention. Then the drug of choice, which is diazepam, 1 mg per kg. IV has to be given. Up to 10 mg, diazepam can be given to the patient. So that is the first aid measurement for seizures. The office management for seizures is the chair has to be lowered to a supine. Patient is made in the supine position, protected from injuring himself. We need to provide the patient with a mouth probe, that is to prevent any tongue biting or anything, and also maintain the airway. And the next thing we give is diazepam 1 mg per kg up to 10 mg. Also, we can provide the patient with oxygen. So seizures is requiring a first aid measurement as well as an office management. And the drug of choice is diazepam. Next question is drug of choice for absence seizures. Options are valproate, phenytoin, diazepam, and carbamazepine. So here the appropriate answer is valproate, valproic acid. So valproic acid is again an anticonvulsant drug. It's a broad spectrum anticonvulsant drug. Yeah, and it causes very little sedation. It has got a fast onset of action, and it causes less sedation and other central effects. So the side effects are also less. How does it act? What is the mechanism of action of valproic acid? So valproic acid is prolonging the sodium channel inactivation, and also there is weak attenuation calcium mediated T current and augmentation of release of inhibitory transmitter GABA by inhibiting its degradation. So that is how valproic acid acts. It is an anticonvulsant drug. Valproic acid is an anticonvulsant drug. It is having a fast onset of action and a prolonged action, and it causes very little sedation and other central effect. So that is the drug of choice for absence seizures. We need to note that for seizures, the drug of choice is diazepam, and for absence seizures, it is valproic acid. So next question is a 32-year-old obese woman has polyphagia, polydipsia, polyuria. So polyphagia is overeating, polydipsia is thirsty all the time, and polyuria is going for urination in quite a lot of intervals. So she was on an irregular diabetic treatment for 3 months, and her FPS is fasting blood sugar, was found to be 140 mg per DL, and PPBS, that is postprandial blood sugar, is 240 mg per DL. Which of the following investigations would ideally suit for the patient's follow-up? So here we can note that the fasting blood glucose as well as the ppps postprandial is looking high. So we need to pick up the correct option. That is option A, glucagon levels, HbA1c, insulin levels, and GTT. So the appropriate answer here is HbA1c, glycosylated hemoglobin. So HbA1, so that is the diagnostic test. So the diagnostic test for diabetes mellitus is HbA1c, also known as glycosylated hemoglobin. So it is a long-term objective assessment for the degree of glycemic control by HbA1c. It is like the hemoglobin in our body. There is a non-enzymatic glycosylation which is happening to the hemoglobin, and it is taking place over a period of 90 to 120 days. So the 90 to 120 days, that is the lifespan of our RBCs. So there is a non-enzymatic glycosylation of HB. So that is how we are getting this HbA1c value. And it gives an estimate of the diabetic control for the past 3 to 4 months. So when you take this HbA1c value, we are getting a average value for 3 to 4 months. What is the diabetic control of the patient? So advantage of no dietary preparation of fasting. There's no fasting required like FPS and like GTT. So, and the good measure for prediction of microvascular complication also. So the diagnosis of diabetes mellitus is glycosylated hemoglobin, which is giving an average value of diabetic control for the preceding 3 to 4 months. So what is glycosylated hemoglobin? Non-enzymatic glycosylation of HB, which is taking place over a period of 90 to 120 days. Okay. Next one is a 60-year-old male patient who is a chronic smoker for more than 20 years. He is having dyspnea, non-productive cough, pursed lip breathing with tightness of chest, normal wheeze. What is the diagnosis of the patient? And the options are interstitial lung disease, bronchogenic carcinoma, asthma, and chronic obstructive pulmonary disease, that is COPD. So the symptoms of the patient is having dyspnea, that is breathlessness, non-productive cough, pursed lip, and tightness of the chest. So these are the classic symptoms of chronic obstructive pulmonary disease, dyspnea and non-productive cough. So COPD is consisting of some entities like chronic bronchitis, emphysema, bronchial asthma, and bronchiectasis, and small airway disease also. So there are two classical phenotypes which can be seen in COPD, that is the pink puffers and the blue bloaters. So pink puffers, they will be having thin and breathlessness, and blue bloaters, because it is blue bloaters, as the name suggests, they are having hypercapnia, that is increase in the level of carbon dioxide, edema, and also secondary polycythemia. So in pink puffers, there will be normal partial pressure of carbon dioxide, but in blue bloaters, there is increased partial pressure of carbon dioxide. Yeah. So what happens when there is predominant emphysema and what happens when there is predominant bronchitis? When there is predominant emphysema, the patient will be having increasing severe exertional dyspnea. That is, patient will be having breathlessness. And the patient will not be having that persistent cough. But in bronchitis, there will be this persistent cough with copious expectoration for a long duration. That is, for as long as 3 months, the patient is having a cough with copious expectorations. And the chest is barrel-shaped and hyper-resonant in the case of emphysema. In emphysema, the cough is occurring later after dyspnea starts, and it is also not having much of this sputum. There can be recurrent respiratory infections, which is seen in bronchitis, which is not frequent in emphysema. In emphysema, there is a common weight loss, and the chest X-ray, the difference in the chest X-ray of emphysema and bronchitis is in emphysema, there is a small heart with hyperinflated lungs, and in the other one, there is enlarged heart with prominent vessels. So, what is the difference between emphysema and bronchitis? In emphysema, there is no cough initially. There is cough after, later, in the later stages after dyspnea starts. And there is not enough sputum. Very scanty sputum is seen in emphysema. But in the case of bronchitis, there is persistent cough for as long as 3 months, and there is expectorations also. In emphysema, there is no recurrent respiratory infections, but in bronchitis, there is recurrent respiratory infections. And the chest X-ray will show a very small heart with hyperinflated lungs in the case of emphysema, and enlarged heart in the case of bronchitis. So that is the two entities of COPD. So yeah, sorry. COPD is a chronic obstructive pulmonary disease, and it is having some entities like in which chronic bronchitis and emphysema are the most common. So the two classical phenotypes have also been discussed, which is pink puffers and blue bloaters. As the name suggests, in pink puffers, there is normal partial pressure of carbon dioxide, and blue bloater is having hypercapnia. Yeah. Antibiotic prophylaxis is recommended in repaired congenital heart disease, repaired cyanotic heart disease, myocardial infarction, and prosthetic valve replacement. So the antibiotic prophylaxis has to be given in some patients. Which are the patients who require this antibiotic prophylaxis mainly? The main condition where we have to give antibiotic prophylaxis before we take up any dental procedure, that is any in interventional dental procedure, is a prosthetic valve replacement. So in antibiotic prophylaxis, there are cases where there are cardiac diseases where it is recommended, where it is not recommended. So there in where there is recommended, you can divide it into a high risk category, a moderate risk category, and a negligible risk category. So a high risk category is where there is prosthetic cardiac valves, where there is bacterial endocarditis and congenital heart disease. So these are the high risk category where prophylaxis is highly recommended. Moderate risk category is any other congenital cardiac malformation, any valvular dysfunctions like rheumatic heart disease, and hypertrophic cardiomyopathy. And the negligible ones are arterial septal defects, surgical repair of atrial septal defect, and previous coronary bypass graft surgery. So antibiotics prophylaxis, what is the antibiotic mainly which we give in antibiotic prophylaxis is amoxicillin, 2 grams, 1 hour before the procedure. And in case of amoxicillin allergy, we are giving ampicillin 2 grams, IV or intramuscularly also it can be given. All these has to be given 1 hour before the procedure is started. And the high risk category for antibiotic prophylaxis is inclusive of prosthetic cardiac valves, bacterial endocarditis, and congenital heart disease. Yes. The next one is cross infection in hospital is best prevented by option 1 is fumigation, proper hand hygiene, antibiotic prophylaxis, and disinfection with sodium hypochlorite. This is a very simple question. So the answer for this is proper hand hygiene. So before any of the other methods of disinfection, like be it fumigation, antibiotic prophylaxis, or other sodium hypochlorite, any other method, before we go to that, we need to ensure there is proper hand hygiene. That is the first step of preventing cross-infection in hospitals. Yeah. An otherwise normal female is complaining of fatigue, malaise, and generalized weakness. She is also having purpuric spots on her fingers as an incidental finding. She reported to the physician who asked for lab diagnosis for further evaluation. So the CBC is showing decreased HB levels. The hemoglobin levels are low. So here, the main symptom of the patient is fatigue, malaise, generalized weakness. Along with that, there is purpuric spots, which is seen on her fingers. So the diagnosis for this is A, aplastic anemia, B, vitamin B12 deficiency anemia, folate deficiency anemia, iron deficiency anemia. So purpuric spots is a major symptom of aplastic anemia. So aplastic anemia is a normocytic, normochromic, macrocytic anemia. So this aplastic anemia is mainly seen when there is a bone marrow failure. When there's a bone marrow failure, there are chances where the RBCs are not formed. There is lesser number of RBCs which is produced. So it can be seen in pancytopenia, leukopenia, and thrombocytopenia. So what is pancytopenia? Pancytopenia means all the blood cells are reduced in number. Leukopenia is a deficiency of leukocytes, that is WBCs, and thrombocytopenia is a deficiency of platelets. So this is mainly seen in bone marrow failures. It can be because of bone marrow damage, as in case of any infection, inflammation, cancer. So aplastic anemia can be seen when there is a bone marrow failure. So it is a normochromic, normocytic, and macrocytic anemia. And you can also see this purpuric spots on the finger. Kayser-Fleischer rings and sunflower cataracts are due to deposition of which of the following? Lead, bismuth, ceruloplasmin, and glycogen. So Kayser-Fleischer rings and sunflower cataracts, it is a characteristic feature. It is a symptom or characteristic feature of which disease? It is Wilson's disease. What is Wilson's disease? It is an autosomal recessive disease. And it is a disease where there is, there's a problem in the copper metabolism. So yeah, so Kayser-Fleischer rings and sunflower cataracts is because of Wilson's disease. And what is the option? What is the right option here? Lead, bismuth, ceruloplasmin, or glycogen. So it is the third option, that is ceruloplasmin. Ceruloplasmin is a protein which is present in our body. So ceruloplasmin, it helps in the copper metabolism in the body. So as said, Wilson's disease is an autosomal recessive disorder of copper metabolism. And in this case, you can see that the total body copper is increased. So this excessive copper can be deposited in the eyes and other organs. So it causes damage to several organs. And amount of copper can be normal at birth and then it increases steadily. So which are all the organs which is affected? It can be in the liver, basal ganglia of the brain, eyes, kidneys, and skeleton. Also, you can see acute hepatitis progress to liver failure. So Kayser-Fleischer, excuse me. Yeah. Yeah, so Kayser-Fleischer rings and sunflower cataracts, it is a feature of Wilson's disease. So Wilson's disease, again, it is an autosomal recessive disorder where there is a problem in the copper metabolism. So in that case, there will be excessive copper which is deposited in the body, can be in the brain, eyes, kidneys, and skeleton. Also, acute hepatitis, which is leading to progress to liver failure. So ceruloplasmin, again, is a protein which helps in copper metabolism in the body. So yeah, so this case of Fleischer rings and sunflower cataract is because of ceruloplasmin. That is a right option. Yeah. So manifestation in the eye because of Wilson's disease is rings, and can also be seen in 60% of the adults with Wilson's disease. So this rings is like it can be seen as greenish brown discoloration in the corneal margin, appearing first at the upper periphery. It can also it can disappear with treatment also. Yeah. So it is a manifestation of the eye, case of Fleischer rings, which is seen in the cataract as a greenish brown, which is seen in the cornea as the greenish brown discoloration. And it is a manifestation of Wilson's disease. So that was the last question for today. I hope the session was, it made some sense to you and you were able to crack some questions among these questions, what we have discussed. Yeah. So thank you.